Bismillahirrahmanirrahim. Now we are going to look at the metabolism in the pharmacokinetics. So the third stage which we need to discuss is the metabolism. So just recall your mind. We have for here is GAT tract, and on this side is blood vessel. So our drug move in the intestine. Our first step was the absorption, and if intravenous no need for the absorption, then the second stage was we have discussed, that was the distribution, and the third stage which we are going to look at is the metabolism. So pharmacokinetics, we are still here. So pharmacodynamics is our next target. So we are going to look at the pharmacokinetics. So metabolism, or we call it the biotransformation. So what is our goal in the metabolism? Our goal is to excrete the drug from by making it more water soluble metabolite. So that actually help us to excrete. So in this sense, by making them more water soluble, what will happen to the drug? So because why we are other concept, why we are making them more water soluble, because if it's a lipophilic, you know better, lipophilic has ability to absorb. So same thing for the reabsorption. So if it's a lipophilic, it can absorb at intestine level. So if it's go to the kidney, so in the renal tubule, in the especially the distal tubule, where they can ability to reabsorb. So for the excretion, best way is with more water soluble metabolites. So what is the location of the biotransformation? Major organ is of course the liver. So but some drug, other drug, specific drug, they can be metabolized by the other tissue, by the lungs, or the, you can say, the lungs, skin, and different other tissue. So but specific drug, major organ is your liver. So what will happen to the drug? If your drug is active drug, so it can convert into the inactive metabolites. Okay. So for example, most of the drug, same thing is happening, they are inactivating by the biotransformation. So but some drug, if they are active drug, sometimes they are still active after the biotransformation. So for example, allopurinol, which is converted into the alloxytone. So another is digitoxin, which is important especially in the heart failure patient. So this is also actually is a biotransformation occurring here. So most benzodiazepine or SSRI, so these all are the active metabolite still after the biotransformation. If you move forward, some prodrug. What do you mean by prodrug? Of course, you are thinking it's an inactive drug, so they can become active by the biotransformation. So it is another way. So many anti-metabolites, so they undergo they activated by the biotransformation. So some drug may become toxic. So they are toxic metabolites. So for example, methyl alcohol, they convert into formaldehyde, which may lead to blindness. So okay, so we can say our drug is not necessary by the biotransformation is inactive. Most of the cases it's inactivated, but sometimes it can be converted into active metabolites, and it can be converted into if it's an inactive form, it can come into the active form. Some drug can enter into the toxic form. So it's depending upon the nature of drug. So all drugs do not undergo all the process. Some go under the first, you can say, inactivation, some undergo the activation, some undergo the toxification. Okay, very straightforward. So cortisone is actually, here is another example which is mentioned here. That is the corticosterone, which is actually a inactive drug. By the biotransformation, they are coming into hydrocorticosterone. Now, biotransformation. So in this sense, actually, here is our path. Our path will be for the making drug more water soluble is dependent upon two phases. Now, phase 1 and phase 2. Okay. So I am before I go to detail, just I draw the concept. What is, as I mentioned, our concern is the making drug more water soluble. So we undergo for the biotransformation into two phases. For example, I take a drug. For example, here is a drug. Okay. So I undergo phase 1 and phase 2. I am making more water soluble. So let's see. In first phase, what will happen? This drug converted into by addition of oxygen. For example, oxidation is occurring here. Two hydrogen ions are added. So what will happen? This drug converted into the OH group. So now and water. So you can see this drug, which now it has some polar group. So it's become water soluble or hydrophilic somewhat. But if it's highly lipophilic, so it has to enter into the phase second, where what will happen? So we know it's still unable to excrete. So we put some polar group, major conjugate molecule here. So for example, in this case, if it's a ROH, so what in phase 2, what will I do? I remove this hydrogen and put a, for example, a conjugate molecule right here. Okay, so this bigger molecule. So this is actually conjugation. So I am simply giving them the conjugation. Okay. I am simply adding the bigger molecule. It's making it more water soluble, more polar. Okay. So while here is a less polar form. So in some cases, it's not necessarily all of our drug undergo the your phase 1 and phase 2 this series. If for example, if a drug has already OH group, for example here, is there any need to go into phase 1? Of course not. If it's already has a some other polar molecule, so it directly enter into the phase 2 and excreted. Sometime also happen our drug can come phase 1 and then enter into the phase 2. So we can say it may have both phase 1 and 2. It may have first they enter 2, then they come back into 1, and sometimes it may happen phase 1 to phase 2. It's not necessary. No, you can say any principle. So they have to enter first phase, then they have to enter into phase 2. So it's dependent upon the condition. Okay. So this is our whole journey. First we look at the phase 1. Phase 1 is actually dependent upon majorly. You may hear the cytochrome T450. Okay. So this is actually a bigger family. It's a super family where you can say RM couple of enzyme more than 300 or 400 you can say. So their enzyme are present. So it's a big family, not a single enzyme. So for example, how we can classify? We simply name them like this. This is for example cytochrome 3A4. For example here. So this if what this name show? This show actually your super family name, that is your cytochrome P12. This is super family. This 3 represent the family name. This A represent the subfamily. This 4 actually represent the actual enzyme. Okay. So in this way we classify this large number of the cytochrome P450 enzyme. So our most of the drug undergo the metabolism by this process. Okay, so this is phase one. Phase one has actually two parts. Phase one has two. One is a microsomal, other is non-microsomal. Okay, so what does it mean? So those drugs which undergo the you can say oxidation or reduction or hydrolysis by the help of this cytochrome P450, mean they are P450 dependent. Okay, so they are the microsomal. The other which there is no need for cytochrome P450. So those you can say polar formation is the actually non-microsomal. Okay, so we first will look at the detail of somewhat the cytochrome P450 and microsomal and non-microsomal. Then we go into the phase two. Now the next concept which I want to share with this cytochrome P450. As I mentioned, most of drugs are metabolizing by this. Okay, so if I give an other drug which is increasing the synthesis of the cytochrome P450 enzyme, what will happen to the drug B? For example, here is a drug A is you have given which undergo the P450. Okay, they are metabolizing by the P450. If I give another drug, for example B, it affecting what they are actually increasing the P450. What will happen to the drug A? If I ask you, you simply think it, of course, if they increase, mean their metabolism will be increased. And okay, so what will happen? Of course, their action will be duration of as they are more metabolized, mean easily excreted, mean their shorter action. If this be, for example, another drug, here is a C drug, which actually is doing what? They are, for example, they are decreasing this. If they decrease the P450, mean they are decreasing the metabolism. So as they decrease the metabolism, mean they are decreasing the duration, increasing the duration of action, mean they will stay in the body for longer period. So we need to, so drug B is considered as the inducer, drug C is considered as the inhibitor, mean they are inhibiting those enzymes which are which metabolize in the process. So this is the whole idea we need to look at in the although all these information are present here just to connect your mind. So let's look at our continue our journey. We were discussing the phase 1 and phase 2. As I mentioned, our phase 1 has two parts. One is the microsomal, other is the non-microsomal. So microsomal, which is cytochrome P450 dependent. So where actually we discuss the different process. For example, oxidation, three major process: oxidation, reduction, and the hydrolysis. These are the reaction which undergo in the microsomal part. While in the non-microsomal, where we discuss the hydrolysis, the monoamine oxidases, so and the alcohol metabolism. So these are cytochrome P450 independent. So they are dependent, they are independent. Why we call them microsome? Because this P450 cytochrome P450 enzyme, they live in the smooth endoplasmic reticulum. They live like a microsome where they look like so. That's why we name them the microsomal and non-microsomal. So what is concerned, they make less polar and water metabolism. So after this, it's not necessarily your drug after undergo the phase 1, they are active or inactive. So sometimes it's maybe inactive. If it's inactivated, so they directly go for the accident, no need for the phase 2. If it's sometimes it's less polar, it's unable to excrete it out, so they undergo the phase 2 where they are highly become highly polar and metabolize. Most of the time, mostly they are inactivated by the phase 2, so they are activated. What are the reaction which help for as I mentioned, the conjugation reaction? So, for example, glucuronidation, so we undergo the acetylation and sulfation and the amination. So, these are different process for the different drug. Okay, now, sometime as I mentioned, phase 2 may precede phase 1 and drug metabolism only by phase 1 or phase 2 depending upon the, because our concern with the excretion. Okay. Now let's look at the phase 1. Our goal is to make the polar and hydrophilic by introducing or unmasking the smaller polar group, for example OH or NH2. So as I just right here, I have introduced the hydroxyl group here. So what is the location? Location is important. So for the phase 1, the location is your smooth endoplasmic reticulum mostly, but in the for the phase 2, its location is the cytosol. So smooth endoplasmic reticulum. So what will be our achievement? Our achievement will be, it could be the active our drug, the activity may be increased or decreased sometime unaltered. So it's not necessary they are inactivated by the phase 1. So the reaction are commonly the oxidation, reduction, and hydrolysis. They are catalyzed by cytochrome P450 system. So as I mentioned, macrosomal and non-macrosomal. So we have covered this oxidation, reduction, hydrolysis. So this hydrolysis is actually by the esterase and amidase. So monoamine oxidase alcohol metabolism. Okay, so these are macrosomal. So major concept is the oxidation, reduction, hydrolysis. Let's see. So you can see here, here is the you can see is the smooth endoplasmic reticulum where you can see cytochrome P450 oxidase are present here. So you can see here the conjugation enzyme. While if the non-macrosomal where the enzyme for those are present in the plasma or in the cytoplasmic enzyme, xanthine oxidase, whatever. Okay. Now let's look at the cytochrome P450 oxidases. What are those? So their most important metabolizing enzyme, as I mentioned, it require oxygen and NADH for their action. So we look at because it's a biochemistry. So if you are interested, I will discuss. So there, as I mentioned, it's a big family. So there are family, subfamily, gene, and family. So cytochrome P4 3A and 2C and 3D. So these are most important families and subfamily, you can say. Okay. So we generally mention these like that type and which is preceded by 3 letters. So you can see here. So these 3 letters are present on the back. So 3A4. So let's see. This type actually represent SYP represent superfamily, 3 represent your family, and A represent the subfamily, while the 4 represent the individual enzyme. So if you look at forward, this A4 is very important because most of your 50% drug are metabolized by this enzyme of the cytochrome P450 family. So hepatic enzyme it's a hepatic enzyme which is most abundant. So it metabolizes the almost 50%. So it may be present in your GAT. So that's why sometimes it causes the poor bioavailability because drug is destroyed by this enzyme. Okay, some other common example which also you need there is no need to remember the complete list, but some important you must need to know. The cytochrome P4 with 3A4, which I mentioned, which is metabolized 50%. Other is the 2D6 and the 2D6 and which is metabolized 30%, and 2C9, 2C19, and the 2E1 and the 1A2. So these are very important. So there is an importance for these D and C. These D and C are actually show the very important. So because they show the genetic polymorphism, mean they are sorry, they are changing from different person to person. So, for example, so some person may be poor metabolizer, intermediate, fast, or ultra fast, ultra rapid metabolizer. I think here is not ultra rapid metabolizer. So, mean what they are depending upon these enzymes. So some person may have increased number of these enzymes. So some has a very low quantity of these enzymes. So which have more in number mean they are ultra rapid. Some who is deficient or have a very low amount. So they are very poor, and some are the intermediate and fast. So this is totally dependent upon the genetic polymorphism. So this idea, if you apply this, because it's important, lot of clinical are applied here. For example, if you have given a patient the codeine and which is actually anesthetic, which converted into by the biotransformation into morphine, what will happen? And the warfarin, which is inactivated by the biotransformation, and tamoxifen and doxyfen. So these are normal biotransformation. What will happen if this person is ultra rapid metabolizer? Okay, it's quickly trying to destroy the codeine into morphine, which is also an active metabolite. So what will happen? The person may lead to death in this condition. Warfarin, what will happen if it's a person is poor metabolizer? Mean it's a poor metabolizer, mean this is anticoagulant remaining in the blood for the longer period, it may lead to bleeding because it's an anticoagulant. So tamoxifen and doxyfen is converted into which is actually for the especially important in the this drug is breast cancer condition. So what will happen in the tamoxifen if it's the you have given for the breast cancer patient because this attaches with the estrogen receptor. So if it's a poor metabolism, it may also mean cause a disease relapse. Okay. So another condition you may find in the 20% Asian are deficient with the cytochrome P452C9, and 2D6 is 5 to 10% Caucasian are the deficient. If it's a poor metabolism, your disease relapse will occur. Okay, so these are some clinical conditions you must need to know for the step 1 especially. Now let's look at what is the importance of your the NADPH and the oxygen. As I mentioned, these are dependent upon the oxygen and the NADPH. Let's see. Here is the P450, and which is in the Fe3 form, reduced form. So oxidized form. So what will happen? For example, here is your drug. You are going to taken up by this P450. This drug so first step what will happen? They are drug complex with the P450 system. So what is the importance of NADPH and oxygen? Let's see. Here is the NADPH. NADPH is converting into the NADP plus, where this electron is gone. So this is actually taken up by the flavoprotein, which take up oxidized form and come into the reduced form. In the next step, what will happen? This reduced form come back to the oxidized form, and this proton, you can say, the hydrogen is given to this P450 system, which was in the ferric form, now come back to the ferrous form. Fe3 plus, you can see now it's come back to the Fe2 plus. So who helping this? The cytochrome P450 reductase is actually helping this. So you can see this, if NADPH is not present, this step will not occur. So in the next step, what will happen? Now it's you can say it's a reduced form. Now in the next step, the importance of oxygen. So oxygen enter into this. So what will happen? Now this oxygen is being attached with the P450 like that. In the very next step, what will happen? Your two hydrogen ions come in, and they take this oxygen and form the water molecule. So you can see here are two oxygen molecules. you can say two oxygen in one molecule. So one oxygen is go to the water formation. Where is other oxygen? This is actually going to attach with the this drug your, for example, RH. So like that, ROH, as they this oxygen is attached with this. So what will happen? Your P450 is come back to the actual form, that is the ferric form, and now it's the oxidized. What will happen? This oxidized ROH will go back, and while this is ready for the next process. So you can see if NADPH is deficient, the oxygen is deficient. So this oxidation could not occur. Mean this phase one will be not happen. So where NADPH come from? Of course, pentose phosphate pathway, where major synthesis is the NADPH is different from the NADH. NADH for the energy production. This is for, you can say, proton electron giver, which is antioxidant importantly. So if it's absent, it may lead to hemolytic anemia condition. One of the major cause of the if G6PD is deficient. So whatever. Now this is oxidized drug which is our concern. So in this way, this process occurs. So microsomal reaction. Let's look at the microsomal. We have, as I mentioned, oxidation, reduction, hydrolysis. So oxidation example, for example, alcohol is first they convert into the your aldehyde, then they come into the acetic acid, finally convert into CO2 and another energy. So this is the oxidation reaction. So if you look at the reduction, where for example chlorohydrate, which is active form, by the reduction they come into trichloroethanol form. So because here is the acidic form, so then they come into the ethanol form, and which is more active form. So this is reduction. If you look at the hydrolysis, especially for the acetylcholine, and here is acid, they come into acetic form and break into the two form, acetic acid and the choline, because it's the acetyl and choline. Okay. So some other example for the hydroxylation and dealkylation and S-oxidation. So these are all are example of your oxidation step. So you can see here. Okay. So, hydroxylation and the dealkylation and S-oxidation. So these are part of the oxidation which is under by the macrosomal enzyme. So for example, phenytoin, which is going to convert a hydroxyphenytoin, codeine, which is going to convert morphine, cimetidine into cimetidine sulfur toxide. So these examples not to memorize, just to connect your mind, because lecture is empty if I don't put these example in the lecture. So just understand what is happening, the major term. So inactivation, activation, so they can be maintain the activation, toxification. Let's look at some example. In the inactivation, your mean your drug is active drug and come back to inactive. For the adrenaline and noradrenaline, so they are inactivating into vinyl mandelic acid. So while activation, in which inactive drug come back to the active metabolite. So for example, cortisone, as I mentioned, they are come back to the hydrocortisone. This is example of your the activation. So for the maintenance, mean they are still active metabolite. So there's a one, so which is actually most of the people take as a sleep pill. Okay, so it's remain in the active metabolites after the macrosomal reaction, toxification for the methyl alcohol formaldehyde convert, which may cause the blindness. Okay. So now these are some macrosomal. Now let's look at the non-macrosomal hydrolysis, which is especially occur by the estases and amidases, while the monoamine oxidases mean they are amine dependent. So if you look at the other, that is the alcohol metabolism. So just need to look at what is important. You must need to do. Hydrolysis is the addition of water molecule with the subsequent bond. So Actually, these esterases and amainases help us the addition of water and with the bond breakage. So bond is broken by these are the monoamine oxidase. As the name represents, so they are amine dependent. So if it's these amine could be are endogenous or exogenous. Endogenous amine example are dopamine, norepinephrine, serotonin, or the exogenous, for example, tyramine. So they all are oxidized by the this in there. For the alcohol metabolism, as they you know better, so alcohol first they come into the aldehyde form, so then after they go into the acidic form by the these whole processes are occurring by the dehydrogenase enzyme. Okay, so you can see just example for oxidation and reduction and the hydrolysis. For example, phenylethyl warfarin, how they are oxidation occur. Oxidation means addition of water molecule or removal of hydrogen, a proton or the electron. Okay, so let's see. So the oxidation here. So you have added the hydroxyl group right here. Okay, for the reduction, for example, the clonazepam and dantrolene. So some reaction are important for some drugs, some reaction are important for the other drug. So reduction for this. So for example, RNO2 is converting it by the addition of water molecule. What is happening? They are converting into the RNH2 form. So this is reduction. Okay, so you can see hydrogen is coming right here. Hydrolysis, procane, succinyl, choline. So there is important for the hydrolysis means simply as you add the water molecule, what will happen? This molecule will break into two pieces. So RCOOH and ROH. Two molecule has been given. Okay, so these are some example of no, inducer and the inhibitor. As I mentioned, inducer are what which they increase the synthesis of your cytochrome P450. So as they increase the macrosomal enzyme synthesis, what will happen? Our metabolism will increase. As the metabolism increase, means duration for the action will be decreased. So when the example are carbamazepine, rifampicin, smoking, while the non-macrosomal, the inhibitor, they actually decrease the macrosomal synthesis. Vice versa will happen with metabolism will decrease, but the duration of your action is going to increase. So this is some clinical importance. Mean if a duration of action mean its metabolism decrease, mean your drug is living in your body for longer period. It may lead to some toxicity. So in the inducer, what will happen? Mean your duration of action is decreased. Mean as your actual problem is not solved because it's as the other drug which is metabolizing the for example B drug is metabolizing A drug. Mean their duration of action is for the shorter period. Mean actual issue is not resolved. Okay. So oral, for example, in the common example which you come and see oral anticoagulant or oral hypoglycemic, oral contraceptive. So their duration of action is decreased by these common example are smoking or rifampicin or carbamazepine. So cemetery, the SN grapefruit juice is very important example. So this is complete list of the your inducer and inhibitor. So just for the some friend, the other important tested example is the chronic alcohol and the acute alcohol. What is difference between the acute and chronic? Acute is in the early stage, while the chronic is mean it's addicted for the longer period. So chronic alcohol cause the induction. So because they are actually increasing the macrosomal enzyme synthesis. So just need to don't confuse with the chronic alcohol and the acute alcohol condition. In the acute alcohol early condition, they are affecting the cytochrome P450, so they are actually decrease the synthesis. But as the time continues, he continues the taking this mother of all abuses alcohol, so they affect the cytochrome P450. They actually act like the inducer. So For some mnemonic, for some friend who want to understand the inducer, and for some example which is commonly you need to know at least to pass some pass exam. GPRS cell phone for the inducer. G represent grazophilin and the P represent phenetin and reformapicin, and the S smoking. C represent actually carbamazepine, and PH represent phenobarbital. While the inhibitor, just vitamin K cannot cause enzyme inhibition. For example, V represent valproate, K represent ketoconazole, and C is cimetidine, and the E represent erythromycin, and I represent isoniazid. So these are some common examples. So for the mnemonic, so now come to the actual issue: inducer and inhibitor. For example, statin is a common example. Statin, a patient who is taking statin, what is the use of statin? Cholesterol inhibitor, synthesis inhibitor. Mean if a patient has cholesterol issue, he is maybe taking the statin. As he taking statin, if he after this taking this drug, he also take the grapefruit. He drink the grapefruit. What will happen? Rhabdomyolysis. What is the rhabdomyolysis? He feel his muscle are going to die. His muscle are all the skeletal muscle are start you can say pain like condition. Why? Because the grapefruit juice is inhibitor. Mean they increase the statin level, which statin can affect the statin toxicity. So which lead to rhabdomyolysis. So rhabdomyolysis, if it's severe, it may lead to death. So these are very important for the clinical condition. So other, for example, if I say carbamazepine, for example, a woman, a lady come to the hospital and is complained, I have taken the oral contraceptive, but she pregnant. What is mechanism? You need to understand what is the history of the medication. In the history of medication, you will see he is taking the inducer. So as the inducer do what? They destroy them because they increase the metabolism, mean the duration of action of the your oral contraceptive will be decreased. So that's why she become pregnant. So these are some very common examples. So grapefruit juices, as I mentioned. So the tacrolimus, which actually, for example, someone is taking for the if after transplant, any transplantation organ, he is taking tacrolimus. So what? But he is also taking Astrid Jones wort, which is actually a somewhat, I think, antidepressant type drug, which is herbal nature. It's you can see in the any medical store, it's commonly present. So because it is what? It is actually inducer. So they decrease the duration of action for this, so transplant organ rejection will occur. So other example, if you look at the contraceptive, as I mentioned, carbamazepine is taken. So the duration action for the contraceptive will decrease, so lady become pregnant. Okay, so to remember, because these are important, this completely is important for the your step 1 exam. So also we discuss into different compartment and special when we go to the special pharma especially. So for example, these carbamazepine, barbiturates or phenetin, so these are all are the anti-seizure drug, while the reformapicin or grazophilin, these are antibiotic. Astrid Jones wort, as I mentioned, it's an antidepressant, and the modafinil, which is actually especially who has the sleepiness condition, are they, so they take those people sleep disorder. Where the cyclophosphoramide is an anti-cancer drug. Well, these two drugs, ephedrine and nevirapine, so this is actually HIV drug. So these are two very important, because you other most of the HIV drugs are the inhibitor. So these you should careful regarding these two drugs because these are the inducer. So if you look at the inhibitor list, so this myodaronism, which is commonly used as antiarrhythmic, so metadine, which is anti-ulcer drug. So these all are the antibiotic. Your isoniazid is, I think, also antibiotic. Grapefruit juices, as I mentioned, because why they are causing the rhabdomyolysis, because the grapefruit juice contain the furoconomerins, which actually affect the means you can say they increase the they are inhibitor for the metabolism of the statin, so they lead to rhabdomyolysis. So as an antibiotic retinol, as I mentioned, these are all are HIV drugs. So most of the HIV, which is protease inhibitor, so they are the inhibitor. So while the vermapil are the diltiazem, so these are actually your calcium channel blocker. So these are inhibitors. So you because as you continue journey, you will see all these examples. When we discuss each drug, you will see there is mentioned in their description. It's the inhibitor or the inducer. Warfarin, and for example, one is taking warfarin, but he is also taking omeprazole. So what will happen? Bleeding will occur because they are leading to warfarin toxicity. Okay. Now let's look at this picture into graph. For example, drug concentration on this side time. So this is actually metabolism, and what will happen by the this is normal. So this is actually show the action of your inducer. Induction means this metabolism is occurring in the shorter time. So while for the inhibitor, so this graph will be shown that is show actually inhibition means your duration of action is increased. So this graph is also tested in the step 1 exam especially. Now there is some important fact you must need to know as a doctor for the neonatal patient and the adult. Lot of differences in the neonates and the adult. For example, if I mention some of them. Okay, so if you look at what is difference in the neonates, so they have actually proportion of body water is larger as compared to adults. So mean they have large volume of body water, mean their volume of distribution will be high as compared to the adult. Okay, so we need a higher dose as compared to the adult in some condition. Okay, so not for all drug because they are watery, not a lipophilic. So for the water soluble drug, we should be careful. They have large VD. Okay, while they have blood brain barrier immaturity, so they are immature in the. So what will happen? Mean most of drug can enter into CNS, so they cause the CNS toxicity. Okay, so if you look at the come to the metabolism differences, for example, they have the cytochrome P450 enzyme activity is less. Okay, so mean they are more sensitive to the, and they are also hepatic glucuronidation, which are also enzyme for the conjugation reaction. So because of these less number of the cytochrome P450, so they are more sensitive to those drugs which are completely metabolized by the hepatic because they have less number of these enzymes. Okay, for the elimination as compared if you look at compare with the adult, so they have low blood flow and low GFR. So that's why they require lower doses, lower doses of renally excreted drug. Because if you give the higher doses, they may not properly active because your GFR and the renal blood flow to the kidney is less as compared to the adult. Okay, so you should be careful regarding the, especially I think the pregnant and the neonate. You should be very careful because a lot of clinical problem come into the hospital. So let's see if you look at this graph because graph are very important. So for plasma concentration and time, for example, this show the for the neonates and and this show actually the adult. So you can see the metabolism is almost, I think, 30 to 40% difference is present in the newborn. So this is 30 to 40% lower as compared to the adult. Okay, so now, now let's look at the phase 2 reaction. I think phase 1 we have a lot of concept we have covered. Now in the phase 2, as I mentioned, if the drug is your is sufficient lipophilic, so in those cases we go for the second phase by the conjugation. Conjugation For the conjugation, we need actually transferase enzyme. So transferase enzyme do what? They actually add this endogenous substrate, different substrate. They add endogenous substrate for a glucuronidase, acetate, amino acid, sulfate. So they add this bigger molecule with the drug. So they become highly polar and highly hydrophilic. So they can be easily excreted out. Okay. So, what is the location? The location is the cytosol. For the phase 1, the location was the endoplasmic reticulum. So, what is the achievement? Most of the time, we actually inactivate the metabolite, so that's why it can be excreted easily. The reaction which is glucuronidation, acetylation, sulfation, all these are the conjugation reaction. So, let's see. In this example, for the aspirin, the both phase 1 and phase 2. For example, here is aspirin. So they undergo phase 1 and phase 2. Here is aspirin molecule, you can see. So in the first step, what will happen, as you know better, so the oxidation reaction is going to happen. So hydroxyl group attach, so they form the salicylic acid. So in the phase 2, what will happen? In the conjugation will occur. So how this happening? For example, this molecule is right here. So they actually hydrogen is removed and the a lot bigger molecule is conjugated with that. That is the glucuronidation. Okay. So this bigger molecule is attaching with it. So this is your glucuronidase is adding with the your this is, so it can be easily excreted out. Okay. So sometimes phase 2 may precede phase 1, as I mentioned, drug metabolite, some drug only by phase 1, some may be by phase 2. Now, you can see some conjugation reaction. One very important is your glucuronidation and the glutathione conjugation. So they all occur, as I mentioned, OH or COH, Na2 different. So our red group, if they are present, so they undergo the glucuronidation. Glutathione for the epioxide and organic halide, acetylation for Na2SO, SO2Na2 OH group. So the acetylation, if these group are present in the drug, so they can be acetylized. So for the amino acid, COOH should be present. For the methylation, Na2SO2 Na2OH group should be present. So for the sulfation, so these are some common examples. But for mnemonic to enlist some of them, we actually use mnemonic games. G represents glucuronidation or glutathione conjugation, A represents the acetylation and amino acid conjugation, M represents the methylation, S represents the actually sulfation. So just to enlist some the conjugation reaction. Okay, so as I mentioned, an example of some conjugation reaction are the endogenous reactant which needed an example. Let's say glucuronidation, acetylation and the methylation. Glucuronidation, aspirin, morphine, paracetamol, so they are all undergo the glucuronidation while the SNRI are depsone, so and the dopamine they undergo the methylation. So what are the reactant they need and what are the enzyme needed for this glucuronidation, acetylation and methylation? For the glucuronidation, we need UDP glucuronic acid with the glucuronyl transferases. Okay, so they need UDP glucuronic acid. So this transferase is important. If this transferase is absent, means your glucuronidation cannot occur. So it's a genetic problem. Okay, especially in the neurate problem. So for the acetylation, we need acetyl-CoA first thing, and the transferase enzyme which actually transfer this acetyl-CoA enzyme to these different drugs, as I mentioned as they said. So for the methylation, we need S-adenosyl methionine and methyl transferase should be present, which actually transfer this group towards these different drugs which have already some smaller polar group. Okay. So here are some clinical examples you should be know for the glucuronidation and glutathione conjugation. Some common for the acetylation sulfation. Some point. So as I mentioned, they need UDP glucuronidase, UDP glucuronidase, and also need the transferase enzyme. So some common drug, chlorphenol and morphine, they are totally dependent upon the glucuronidation reaction. So infants have actually limited ability to glucuronidate. That's why they lead to toxic. If you have given a patient with for example, this chloramaphenol, so what will happen? It will lead to gray baby syndrome in the infants. Why? Because they have limited glucuronide, they cannot do this job. So the toxicity of this is this drug which lead to gray baby syndrome. So like this, so you will see the patient will be have pale blue skin or lethargic. So conditions. So these are very common in the neonates problem. That's why I say the baby. Oh, it's a very important case. So you should be careful. And if you come to the glutamate, as I mentioned, only especially it is important for the acetaminophen metabolism. So let's see, if you have overdose of this, what will happen? This as you overdose mean this process is utilizing more and more by this drug, you go for the depletion of this enzyme. So if you have for in this condition, how you will treat? You simply give the N-acetylcysteine, which actually help for the regeneration of glutathione. Mean you can metabolize more this drug. Okay. And sometimes this may lead to some toxic metabolites. If it's not always, in some cases if it's go to toxic metabolite, mean it lead to liver damage. So these are actually some long line 1 or 2 pages you may be seen in the detail, but the summary is I am sharing with you people. You must need to know acetylation. So the sulfazamine, which is I think anti-inflammatory drug. So hydralazine or procainamide hydralazine, which is anti-hypertensive drug, and procainamide, it's actually anti-arrhythmic. Isoniazid are and they all are metabolized by the acetylation. So these are very important. So mean if someone and this is very again it's tested on your exam then because there is genetic polymorphism. Someone have fast acetylator, someone has slow acetylator. Mean they have slow acetylation capability. There is some important because some patient have fast acetylator, some are the slow acetylator. Mean they have low capability to perform this job. What will happen? Mean of course if you have given isoniazid to a patient, so it will lead to lupus-like syndrome, which is like systemic lupus, erythropoietin, whatever it is. I think okay. So it is actually when these patients actually come into clinic. So if you have given isoniazid to a slow acetylator, so these conditions come like this, where you find throughout the systemic problem. For example, like you will see they have rashes on the skin, they have cardiac problem. They will show some it's a syndrome because there's some renal problem. So throughout the body you will see the problem of the toxicity of SOD. So okay, lupus like syndrome will appear. So genetically mediated. So because especially this is for the American people, African and American, and the Caucasian people, which has 50% of the slow acetylator. So that's why you will be careful regarding those people. For the sulfation, so only it's very uncommon. So only some drug, for example, if they are steroid nature or the lipophilic or minoxidil, so these are actually undergo the sulfation reaction. Okay, so I think this lecture is over. So thank you very much. We will cover the excretion in the next session. Thank you a lot.